I am Samudra Bora. I'm the Director of Health Services Research Center, and it's my pleasure to welcome you all to our speaker series. Just some few housekeeping notes before we start. This webinar is being recorded and will be available to view from the Health Services Research Center website. Throughout the presentation, please mute your microphones. If technical assistance is needed, please contact the R&E team, Nicole Bollinger or Abigail Zona. They're on the call. If you want to ask questions to the speaker, you can type them in the chat. Questions will be seen by all attendees, and you will have the option to submit them anonymously if you prefer. For those of you who are invited to the meet and greet session after the presentation, please remain on Zoom upon the completion of the Q&A part. So for those of you who are joining in now, this is the 25-26 session of the Distinguished Speaker Series hosted by University Hospitals of Cleveland Health Services Research. Open to the public on the first Tuesday of each month from 11. Invite nationally and internationally renowned experts and leaders to share their perspectives on health services research, population health, and public health. We have 13 incredible speakers for this session, and you can visit our website for more information to register, and Abigail Zona has just now pasted the link in the chat window. And it is now my privilege and honor to introduce our speaker for today, Dr. Sandro Galea, the opening speaker for the 2025-26 session of our speaker series. Dr. Galea is a physician, epidemiologist, and author who has received several Lifetime Achievement Awards. He holds a medical degree from the University of Toronto, graduate degrees from Harvard University and Columbia University, and honorary doctorates from the University of Glasgow and the School of Medicine at Mount Sinai. He is the Margaret C. Ryan Dean of the School of Public Health, the Eugene S. and Constant Kahn Distinguished Professor in Public Health, and Vice Provost of Interdisciplinary Initiatives at Washington University in St. Louis. He previously held academic and leadership positions at Boston University, Columbia University, the University of Michigan, and New York Academy of Medicine. He has published extensively in the peer-reviewed literature and is a regular contributor to a range of public media about the social causes of health, mental health, and the consequences of trauma. He has been listed as one of the most widely cited scholars in the social sciences. He is the past chair of Boston Board of Health, of the Board of Association of Schools and Programs of Public Health, and the past president of the Society for Epidemiologic Research and of Interdisciplinary Association for Population Health Sciences. He's also an elected member of the National Academy of Medicine. With this, I invite you, Sandro Galea, to our speaker series. Over to you.
Thank you so much. Thank you for inviting me. It's really a privilege to be here with you. I'm really honored to be part of your speaker series, and particularly to lead off the speaker series today. I feel a bit of weight of responsibility for the speakers to come. So thank you for inviting me to be with you. Let me share my slides. I presume everybody can see that, yeah? Very good. Yes. Okay, so I want to talk a little bit about the moment, and I sort of feel like there's none of us who are in health right now can see anything beyond this challenging moment that we are in. I think we know it's a challenging moment. I'm not going to spend much time about the contours of the challenge, but what I really want to do is to take this moment and see it as an inflection point for us, and to learn from the moment and to think about opportunities that the moment can lead off. And I was hoping in structuring the talk this way that it would be appropriate both for the series, but also as I looked ahead and saw the other speakers yet in the series, thinking of this perhaps as a bit of a framing as you engage in the intellectual conversation that I know you're going to be engaging in with the other speakers going forward. So let me just show a couple of slides about the inflection point. As you heard from the very kind introduction, I'm now the dean at the Washington University School of Public Health. I moved here in January of this year. So I moved to St. Louis January this year. Our local hometown newspaper is called the Sunday Post-Dispatch. And the very first time that the Sunday Post-Dispatch had anything in it since I arrived here about public health, it was this headline. And I thought that was a bit of an inauspicious start to my tenure as dean at the Washington University School of Public Health, with public health efforts reeling in the front page of the newspaper. Now, of course, that was, I thought, sort of aptly put, because there's plenty of reasons for public health efforts to be reeling. We have a Secretary of Health and Human Services who is upending ways in which we are doing things. There have been a number of data sets that had previously been pillars of public health research that have gone missing. And I think it was enough to make us all feel like the entire edifice within which we operate was on fire, is being re-examined, is being challenged. And I think that is very much the case. And I think one can have many reactions to the moment. One can have a reaction of a sort of a railing against the winds and the fates and saying, you know, these are terrible things being done upon us. Or one can actually say, well, there are things that we hold dear. There are values that are important to us, and we should make sure we hold tight to those values. But there are other areas that perhaps we might want to think and ask ourselves, what are we learning from the moment, and how does the moment point to opportunities? And that's what I would like to do. Because I think it's important to recognize, first and foremost, that the moment is not the moment, it's not the moment. Meaning that while there are a number of things that acutely came crashing around us in the moment, these have actually been building up for many years. For example, while Secretary Kennedy has had quite controversial perspectives on a number of vaccines, and we have had a lot of discussion about how that seeds skepticism about vaccines. Skepticism about vaccines in this country long precedes Secretary Kennedy's tenure. When you look, for example, about measles, there's MMR vaccination, something that we've talked about a lot recently, linked to Secretary Kennedy's comments. You actually see that we've had a decrease in MMR vaccination rate in this country happening for the past 10 years. That the US median has long been below the threshold that's actually we want to have for herd immunity. So the challenge around the population accepting vaccines around measles are not linked to Secretary Kennedy, they long precede him. When you look, in fact, at a map of the country, this is just a stylized map of the United States, and the squares are states. The red, or the brown, whatever color they are states that have a decrease in their MMR vaccination rates over a 7-year period. The blue are was an increase. And what you see is many more states had a decrease in vaccination for MMR than states had an increase. So I'm using this just as one illustration to say the moment has been very dramatic. We have focused on the moment because there have been particular challenges to elements of how we think about health that are important and central tenets to how we preserve the health of the population. So it is reasonable for us to feel this is an inflection moment. It's reasonable for us to feel sort of shaken up by the moment. But it's also important that we recognize that the moment is part of a longer-term trend and a longer-term set of questions about how we actually focus in health and should push us to think, how can we do better? So my second point is, well, how did we get here? How did we get to this moment? Well, I would argue that one of the ways in which we got to this moment, and I want to be clear here, I am speaking from within health. So I am not blind to the fact that there are many other forces that got us here that are outside of health. There are many other political and partisan forces that got us outside of health. But I also think it's easy for us to just blame those other forces. And I think it's harder for us to look at ourselves and say, how are things within health? What are things within health that brought us to this moment? And when you look at things within health, you see, for example, that nationally, we have had terrible health as a country. We have been, as a country, we've essentially lost about 2 decades of progress in life expectancy in the context of COVID, but we have been falling behind on health compared to other high-income countries. Other high-income countries are the blue, the US is green, for about 40 to 50 years. In fact, when you look at mortality, these bars are, the blue bars are US mortality, the red bars are mortality in other high-income countries. You see a U-shaped curve of mortality over ages, which that's standard worldwide. You have higher mortality, younger ages and older ages. But what I want you to see is that the blue bars are higher than the red bars throughout, which means US mortality has actually been higher than mortality has been in other high-income countries for many decades. So we have been living in an unhealthy country. And for all of us who are in the health business, we are all in the business of health. We're all in the health establishment. This has long, or should long, have been a rallying cry, in that it is hard for us to make the case that we should preserve the health status quo when the health status quo is not serving so many people. Now, this has been interlinked with some of the divides, the political divides that have riven this country over the past decade, couple of decades. For example, when you look at mortality rates and you look at it in counties that lean red versus counties that lean blue in this country, you have this yawning and widening mortality gap, with counties that lean Republican having higher mortality rates than counties that lean Democrat in this country. So is it then a surprise that there has grown a disaffection with health, disaffection with the health enterprise that has made space for persons in positions of authority who have posed radical challenges to how we do things in health? Is it then a surprise that parts of the population which have been particularly hard hit by poor health might have actively chosen people to be in positions of power who wanted to challenge the enterprise of health? If you look at this map, this is from a paper that was published just after the election of President Trump in his first term, 2016. This is change in life expectancies on the x-axis and proportion of votes for candidate Trump on the y-axis per county. What you see is if you go left to right, you have better life expectancy over a 40-year period. The better life expectancy, the lower the proportion of votes for candidate Trump, who was a populist candidate. While on the left, the worse the life expectancy, the higher the proportion of votes for candidate Trump. Now, I am aware, again, I'm happy to take some of this up in the question and answer period, but just to anticipate some questions, I am aware of misinformation. I am aware of disinformation. I am aware of fairly cynical attempts to argue against elements that actually might help people and their health. Having said that, my challenge to us is the following. If you have two candidates running for election, one who is a candidate very much of continuity, who says, vote for me, and we will continue doing well. And you have another candidate who says, everything's going to hell in a handbasket, vote for me, we'll rip up the playbook. It is not irrational to vote for the populist candidate who promises to rip up the playbook if you feel like your health and the health of people around you has been getting worse and worse over the past 40 years. And by the way, this phenomenon that a populist candidate gets elected and the populist candidate carries the weight and the vote of people who are whose health is doing worse is not unique to the United States. If you look at Europe, you see on the x-axis, you have general health or hampered by disability. From left to right, better health to worse health. This is the percentage of populist votes. Populists get more votes from areas in countries and from people who feel like their health is doing worse. So there's many, many reasons that brought us to this current moment. But certainly, I think we in health have a responsibility to hold a mirror to ourselves and say, how is it that forces around us that have kept health poor have contributed to the moment that now further threatens health? So in terms of the recent few years, I mean, everything I'm talking about, as you can tell is sort of on a 40, 50-year trajectory. In the recent 5 years, there has been one other particular perturbation, which has been dramatic and has really shaken up everything about health, and that is COVID. You know, we are sitting here in 2025, and I am pretty sure if I were to poll the audience and say, how many of you would like to hear about COVID? Everybody's going to sit on their hands because we are tired of talking about COVID. I understand that. But we cannot actually seriously entertain the question about the challenges of the moment without recognizing that COVID was an enormous perturbation. This is change in life expectancy amid the COVID pandemic. The darker the color are countries that lost more than 6 years, 5 to 6 years, 4 to 5 years in life expectancy. It is hard almost to remember today in 2025 that in 2020, in terms of leading causes of death, what you see is heart disease, cancer, then COVID. A disease that we had never heard of, like none of us had heard the letters COVID put together as a disease until December 29th, 2019. That's for people who are really paying attention. For most of us, it was 2020, right? And then it becomes the third leading cause of death. That is an enormous shock to the system. That is an enormous shock to the system. And that changed not only how we operate in health, but how people see us in health. So if we are serious about an agenda, which I articulated earlier, which is at this inflection point to learn lessons, we have to weave in our learning in terms of learning what happened in the past 5 years during COVID. In the particular context of the United States, it is important to recognize that COVID had a dramatic effect on the health of this country, much more than other countries, but that dramatic effect was superimposed on our underlying poor health. What you're seeing here, if you go on the left panel, the left panel is life expectancy of the US compared to just a sampling of other high-income countries. And you see how much worse we did than other high-income countries. But the right panel actually subtracts COVID deaths. The right panel is a counterfactual, subtracting COVID deaths. And you see that we still do much worse than other high-income countries, right? So this, I like the slide because it brings together all the points that I've made so far in the past 7 minutes, which is health doing poorly, COVID pushes us for our health to do even more poorly. That brings us to the moment. That brings us to the moment and the opportunity in the threat of the moment to reimagine how we think about health. And I'm going to propose 7 areas very quickly, because then I want to make sure we leave time for questions, for how we can reimagine how we think about health. And I'm going to go through them one by one. So let me start with number 1, which is why health. One of my very first points on this is that we need to be careful to think about what we mean when we think about health. Everybody in this audience is sophisticated enough to quote the World Health Organization preamble. I like to go back in time to Herophilus, the founding father of anatomy, who wrote, "When health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, intelligence cannot be applied." What is important about this definition is that what he is saying is that health is a means, not an end. Health is affording us all the opportunity to live rich, full lives. That means that we want to be healthy so that people can actually do this. And everybody in health looks at this picture and all our hearts go warm and fuzzy and say, yes, that's what we want for healthy people to do. But we need to recognize that we want health so that healthy people can also do that. Now, those of us in health, our hearts may sort of take quite a different beat when we see that. Like, why are people flinging themselves off a plane without a parachute? But that is part of what being healthy is about. And the reason I'm challenging us with that at the beginning is because it means that we need to see health as a means to larger societal goals. And when we think about the policies that we endorse and the approaches that we embrace, they have to be seen as reasonable policies within a frame that allows for societies to move forward and fulfill their full promise. So that's point A. Point B, equity should be a foundational value for everything we do in health. Now, I realize, as I say this, I'm not blind to the fact that when I say this, that some people in the audience probably had a small shudder, because we've all heard about the fact that, is equity one of those words that we're not supposed to say? I understand that. I actually think that the notion that we are in the business of creating opportunities for everyone to live full, rich lives is inseparable from the notion of, well, everyone. I said everyone. By everyone, we mean everyone. That means that we should have no health left behind. That means that the notion that when we look at a map of the world and see life expectancy in a world like this, and we recognize there is a 30-year gap in life expectancy between the highest performing countries on health, lowest performing countries on health, that should be unacceptable. When we look at a map of the world and say, look, that's where the burden of disease mostly is, well, that should be unacceptable. When we actually look at the map of the United States and see there's a 20-year gap in life expectancy between counties, that should also be unacceptable. And that we in health need to have the confidence to have the conversation about what is it that drives health gaps? What is it that drives health inequities? There's a definition of health equity, which is it's about the allocation of resources according to need in a way that preventable differences are minimized and that access is fair. That is an ineluctable part of what we need to be thinking about as we rethink what we do in health. Unless we want to say it is okay for there to be health gaps that are unfair. Unless we're willing to say that, which I bet nobody in this room is willing to say, then this needs to be a core part of what we do. That means that from a global lens, when you look at things like that, where you see the share of population living in extreme poverty, well, that should be unacceptable. And that is very much part of the agenda of health. It is important to recognize that these forces are long-standing, deep, and very difficult to fix. When you look, for example, at forces like wealth distribution globally, the red line looks at the top 10% of richest countries in the world controlling 50-60% of the world's total income. You see, that hasn't changed for about 200 years. These are difficult, intractable problems, but they very much are and should be at the heart of what we do about health. It's also important to recognize that while we in this country have spent a lot of time talking about things like disparities around health indexed particularly to identity markers, we should recognize that health gaps extend well beyond that. For example, this is from an analysis that we had done, which looks at heart attack and angina. The yellow dots are the poorest 80% of the population. The green dots are the richest 20% of the population. You see this widening in gaps in heart disease as indexed by the richest 20% versus the poorest 80%. And broadly, what you see, if you look carefully at the data, are a widening of gaps on health indicators between college-educated, richest 20 to 40% of the population versus everybody else. And when we think about health gaps and health inequities, one of the challenges we have in health is communicating this, because in part, this becomes often a feeling like this is a problem, a charity problem, that when we're dealing about health equity, we should just be caring about health equity because we're good people and we don't want people to fall behind in health. No, health equity is foundational to what we do about health. And not just that, it is also a problem of all of us. You know, the problem of any of us are the problems of all of us. And I just want to show you this with just one slide. Before a global pandemic hit the world in 2020, I would make this point by pointing to infectious disease, making the point that if you have some people with infectious disease, it's going to affect all of us. I'm not even going to make that point now because I think that point has become obvious. But let me show you something that we know around which there are health gaps, which is maternal mortality. We know maternal mortality in this country is characterized by enormous racial gaps, that Black Americans have a much higher rate of maternal mortality than white Americans. And as a result, our aggregate maternal mortality is much higher than other high-income countries. It's the US on the left, other high-income countries. We're about 4 times higher maternal mortality than other high-income countries. But when we look at that, we might say, well, that's driven by particular groups who have high maternal mortality. Yes, but not only that. In an analysis, which I quite like, restricting the maternal mortality to the richest 1% of counties among white Americans only, you see our maternal mortality is still twice as high as it is in high-income countries, making the point, I think, very effectively that the problems of some of us are the problems of all of us, pushing us to be unyielding about having a concern with the health of all at the heart of everything we do as we move healthful. Number 3 is being focused on investing in what it is that generates health. We invest a lot in health. This is our total national health expenditures. A couple of years ago, it was about 17.6%. And everybody in this audience knows that our health expenditures are higher than other high-income countries. The blue line is the US. Other colorful lines are other high-income countries. And people may have also seen this graph, which, by the way, this graph also makes it into the Make America Healthy Again report, showing that when you look at health expenditures per capita in the US on the x-axis, for all countries, life expectancy on the y-axis, more health expenditure, more life expectancy, except the US falls off the curve, right? It's like a failures to thrive in our child development charts, that the US spends more and gets less. Why is that? Well, that is in no small part not because we don't spend money, because we do spend a lot of money on healthcare, so $4.5 billion. What you see is we spend it, of course, on curative care. Everybody here knows that. And it's funny because we're constantly in rooms where we know that, but we're almost unable to shake that, right? This is ultimately what causes health. Health and healthcare really matter. They matter 10 to 20% of our health, but what really causes health are smoking, diet, alcohol use, where we live, community safety, having a livable wage, having education, having communities around us. That's ultimately what keeps us healthy. And part of reimagining health, part of making America healthy again, to borrow a phrase, is being clear about what it is that generates health and making sure that we invest in that. That's number 3. Number 4 is balancing health and living. Now, this goes back and ties a little bit to the point I was making earlier, but I do want to lean into COVID example here because I think it's important to lean into COVID example. And I think it is important at this point in our history that we in health are honest about how we went wrong, went off this path. We in health were largely behind things like school closures when we knew consistently that the risk of children to get COVID and get seriously sick from COVID was much lower than other ongoing risks to the health of children, like car accidents, cancer, suicide, homicide. That's the risk of death from children from COVID. But the school closures, which resulted in a lot of opposition to health that remains to this day, has resulted in kids, particularly kids from low-income, less affluent areas, falling behind enormously on schooling. And by the way, these falling behinds are going to stay with this cohort the rest of their lives. What you see on the right is a graph that you see that the poorest districts roughly fell behind half a year, which they're never really going to recover. It's then no wonder, right, that resulted in protests like this, and that resulted in pushback on health and the health establishment. And perhaps that's uncomfortable for us, but the health establishment is us. And I think we need to own this and be clear that we have learned from the moment. I think we should also be clear that we have learned from a moment when we rejected unorthodox perspectives on health. Certainly the current NIH director was one of the right authors of the Great Barrington Declaration, which had a lot of things that one disagrees with, but I think a lot of things that actually were made good common sense. But on the left is what one group, of concerned scientists called that herding people to slaughter. It was this kind of absolutist language that we adopted in health that shut out other ideas that ultimately did not allow us to balance health and living. Similarly, ideas around COVID, like zero COVID policy, which was publicized in editorials in journals like The Lancet on the right, resulted in giving a license to governments, like Chinese government, to actually use zero COVID to essentially exert control over populations. These are all areas in which we in health were not good at balancing health and living. That's number three. Number four. Number five. This is sort of the hard part of my talk. Then I'll get into the rainbows and roses in a second. But points 4 and 5 are the hard points. Uncomfortable ideas for health. So what do I mean by uncomfortable ideas for health? Because I know what I said before is pretty uncomfortable. We're wrong on things in health, and we're wrong not infrequently. And we've been wrong about health for many centuries. I mean, this here is the dominant model of pathogenesis for about 2,000 years. This comes from Hippocrates and says that health is balanced by yellow phlegm and brown phlegm and blood. This is why, by the way, for hundreds of years, we leached people and we bled people because this was our dominant model for health for like about 2,000 years. And, it's sort of all wrong. It's just all nonsense, really. How much of what we do today is actually nonsense, and how sophisticated can we be about learning from that? I like this quote from a feminist philosopher, Judith Butler. They say, the matters most in need of public discussion, the ones that most urgently need to be discussed, are those that are difficult to discuss within the frameworks now available to us. And I like that quote very much, because I actually think we don't really have frameworks for these difficult discussions in health. So just for the sake of putting things in our mind in the interest of a academic conversation like this one, so that people can actually take things with them and think about them, I just want to point out one uncomfortable idea, something that we struggled with because we did not struggle with enough. COVID hits, new infectious disease, we know it's transmitted person to person. An emergency disaster declaration is declared by the president on March 16th of 2020. And we say it's an infectious disease. Therefore, the way to stop transmission or to limit transmission is we should stop being around each other. And if you can work from home, right? And we in health said, yes, if you can work from home, work from home. What happens when you do that? Well, here's what happens. When you do that, the people in the higher levels of income stay at home. That's the gray light. The people in the lower income levels who actually need to work outside the house don't stay at home. Now, that stratification was entirely predictable because we knew before COVID, these are data from 2019 from the Bureau of Labor Statistics, who could work remotely. These are data pre-COVID. On the right bar, the top 25% of income, which is all of us in this room, 62% of people could work from home. On the left part of the bar, lower 75% of income, only a minority of people could work from home. So if you have a new infectious disease and you have a national emergency declaration, which everybody in health gets behind, where you say, if you can work from home, what's going to happen? Well, what's going to happen is, in the first year of COVID, the people who die are going to be the bus drivers, construction workers, manufacturing workers, drivers, laborers, cooks, etc. That's who's going to die. That is what we essentially endorsed. And that's wrong, right? That's wrong. And I think it's important that we grapple with the uncomfortable idea that by not thinking carefully, for example, by holding health equity at the heart of what we did, we have made mistakes. And we knew this. We knew this was going to be the case. We knew, this is from the first month of COVID, data from China, that it was people with underlying disease who are going to be more likely to be the people going to be affected by COVID. Cardiovascular disease, diabetes, chronic respiratory disease. We knew that in this country, there are people, for example, Black Americans, more likely to have high blood pressure, more likely to have diabetes than white Americans, as a result, more vulnerable to COVID. So we could have been much better at thinking about who to protect than we were. Point 6 is thinking about how we do our science. Think about doing population health science that actually is consequential, is helpful to policymakers. If I were to, if I had the courage, I would write a book which was called Follow the Science with a line through it. That was perhaps the worst mantra of COVID, because Follow the Science suggests that the science is dispositive, but in fact, policy decisions in societies are made in part through the science, in part through societal values and discussion and conversation. There is a literature on this. Anybody's interested, I would refer you, for example, to the work of Parkhurst, who talks about evidence for policy requires evidence that addresses the key policy concern, useful to local context, and in a way that uses evidence that emerges from local context. One of the challenges that we had in COVID was how much evidence that emerged from the medical literature that was ultimately not useful for policymakers. And finally, a rethinking about health requires better communication. We all know, everybody's here is aware now of this very simple point, that there's a drop in trust in health, in medicine, and a bit less understood is that the drop in trust is actually quite stratified by income. People with lower incomes are much less likely to trust institutions. There are people with higher income. I go back to where I started about people who are doing well versus who are not doing well. And, helpfully, people do think that scientists are smart. That's good that they think we're smart, but they also think we're crappy communicators. And they're sort of probably right. We probably are. And, again, I'm not saying that in any way just to indict us. It's hard out there. It is hard out there. This is I like using sort of simple graphic. These are people who are unvaccinated, people who are vaccinated. And, the tweet or the X, I don't know exactly what the noun is, that says as many people died who were vaccinated as were unvaccinated is correct. It is, of course, grossly misleading because the proportion of people who were vaccinated who died was much lower than the people who were unvaccinated, right? We all know that. But the reason I'm showing this is because I think this one slide illustrates our challenge in communication, right? We need to communicate concepts that for us are second nature, but they're actually complex and they're hard to communicate. And in a sea of misinformation, in a wave of willful disinformation, it becomes really difficult. And we need to figure out a way to actually make our way around that. So let me end. I'll end on the positive. I actually think that we should end by remembering that health has had extraordinary achievements, that while we are at this inflection point, we should build on strengths and we should take pride in our strengths. Life expectancy in the world, humans have been around in human form for maybe 75,000 years. And for all the time, life expectancy has grumbled along about 30 to 40 until about 150 years ago, when very quickly it went up to almost doubled now, right? That is an extraordinary transformation of the fate of humankind that comes from achievements in health. And although I showed you earlier gaps in life expectancy by showing you the map on the right here, this is the map on the right contrasted with the same map on the left in 1940. 1940, not so long ago, right? It's 80 years ago, a lifetime, really, not so long ago. It was much worse. We are doing much better. And while I have talked about some of the challenges of COVID and using them to help catalyze our thinking, I will remind us that COVID had a lot of triumphs. I mean, we achieved effective vaccines within 8 months of a novel pathogen, which had never been done before. The fastest we'd ever achieved vaccines before was about 3 years. That is an extraordinary achievement. So to conclude, how do we learn from and improve on the past? Well, there's a number of lessons from the past. One of them is that change like this, thinking different like this is not easy. I use the story to illustrate this. The gentleman on the top left is Ignaz Semmelweis, who was responsible for one of the most important observations in health ever in human history, which is the importance of hand washing. He observed that by studying 2 clinics, 2 wards in the same hospital in Vienna, where mothers were giving birth to children. The blue line was the rates of puerperal fever, aka postpartum fever, among mothers who were delivered by nurses. The pink line was mothers who were delivered by doctors. He observed that doctors were doing autopsies down the hall, walking down with dirty hands and then delivering babies. And he said, oh, maybe there's something being transmitted, and maybe doctors should wash their hands. Remember, this is time before germ theory. This is in the mid-19th century. And, you know, he was applauded, given many awards, elected to many professional societies, and, you know, became a hero of medicine. Not so. He was actually, the medical establishment completely turned against him. Leading obstetrician of the day had this quote, which I quite like, which is, "Gentlemen always have clean hands." He was drummed out of his hospital, and he died in what at the time was called an insane asylum. So change is difficult. Change is difficult. And, you know, I'll end on this, which is, initially it seems silly, then it seems controversial, then it seems progressive, and then it seems obvious. I'm not sure exactly where we are in some things I'm saying, whether we're actually at silly or controversial or progressive or obvious, but I'm certainly hoping that we will get to obvious one of these days, not too long from now. I will stop there. If anybody's interested, that is a URL takes you to my blog, which is roughly every week or every couple of weeks, although I'm taking a summer break for a couple of months, where I try to develop these ideas that you have been so kind as to invite me to present to you today. Thank you for having me, and I will stop sharing so we can then have questions.
Thank you, Dr. Galea, for a very thoughtful, thought-provoking presentation, very relevant for all of us here in the audience. Just to remind the audience, if you have any questions, please type them in the Q&A box. If you prefer to have your questions anonymously, you can do that too. And I see that we already have a question in the Q&A box from Timothy.
Oh, I see it now. So I was looking at the chat. I was like, I didn't see it.
Q&A box, yeah.
Hold on. One of the biggest problems I've seen is, oh, okay, it's reflected in the chat too. Now I see both. Is lack of trust in public health leadership. However, to your point, there are incorrect statements made in COVID response and the East Palestine train derailment. Speak more about the need to properly propagate scientific uncertainty to the public. Can everybody in the audience see the question, or do I need to repeat it?
You'll have to repeat it. I don't think. I don't know actually.
Okay.
They can see it if it's in the chat, so you're good.
Okay, good. All right then. So the question is, you know, about uncertain. Oh no, somebody said we cannot see it. Okay, let me read the question. So the question is when I talked about trust, you know, part of the challenge of trust was errors made in public health statements. For example, masks. Masks don't help. Masks do help. Around the East Palestine train derailment, it's safe to return, not safe to return. And these errors compound the lack of trust. So I think it's a very good point. And the question is, can I speak about communicating uncertainty as a prerequisite to earning public trust? So I appreciate the point. And I will frame my answer by saying that I think I'm a little bit in the minority here, because I think the consensus for a long time in health has been, people need to know certainty. People need to be told, this is what the answer is, this is what to do. I have never felt that, and I don't feel that now. I actually think that people, to use the term, we are all people, by the way, people is not them versus us, we are all people. I actually think people can handle complexity. And I think we need to get much better about saying, this is what we know, this is what we don't know. I may know more tomorrow, and when I do, I will come back and talk to you. You know, this is like from the Tom Cruise, Jack Nicholson movie. You know, you can't handle the truth. I actually think we need to earn back trust by believing that people can handle the truth. I think that is a different mode of communicating than we have exercised in health. Certainly different than we exercise in public health. And many of you may disagree with me, and feel free, obviously. But you know, I've been in endless arguments over the past few years where people say to me, no, people need to hear definitive answers. I don't agree. I think when we don't know, we should say we don't know. But I'm framing it by saying that's what I think. Most disagree with me. Next one is, do you think scientists of publicly funded research should be required to post results in social media? It's a good question. I mean, I think scientists have a responsibility to be part of an ecosystem that generously and abundantly communicates the science. I'm reluctant to say you know, in Lydia Furman's question, that the individual scientist needs to post on social media. I think social media is a very particular medium, and some of us are good at it, some of us are not. You know, I'm very, very careful in my words. I said that's why I think we have a responsibility, part of an ecosystem that does that. And I would want to make sure that all science is done within ecosystems that actually communicate abundantly using all media available to them. I'm reluctant to pin it on you, the individual scientist, me, the individual scientist, because we all have different ways in which we can be effective. But I do think it is reasonable to say we, as an enterprise, have that responsibility. From Karuna Ramcharan, how does the American sentiment of individual rights uniquely affect our health outcomes, if at all? Yeah, I think it's a very good point. You know, I think, you know, we hear a lot about this, about, well, Americans like individual liberty and all that. There's no question that different countries, different regions of the country have particularities in the context of culture and values. There's no question about that. But I often think that this notion that Americans like liberty is overstated. I actually tend to think that Americans also like their children to be healthy. Americans have also long abided by all sorts of restrictions. Americans all wear seatbelts. You know, it is, there are many things that we have done that show that when properly explained, when the case is made for why something is health promoting, the population of America does come along. So are there particular traits of different countries? Sure. Are there particular traits that are regional? Like, you know, I lived in Massachusetts. I chose to come to live in a red state, in part, to be completely frank, is because I wanted to be part of the conversation in health from a different lens rather than the East Coast one that I was used to. Is the conversation in Missouri different than it was in Massachusetts? Sure. Do I feel like it's that different? Not really that different. You know, there are differences, but I don't want to overstate them. From Tanvi Sumit, how would you recommend we look at large-scale health disparities as a medical student? Where do we start when making an impact in space? Yeah, I think it's a great question. I think my answer is, as a medical student, you should start by making sure you're an excellent medical student so you can be a great doctor, because that's your job as a medical student. And, you know, you are part of what I'm calling here the health ecosystem. Doctors are a critical part of the health ecosystem. And I want to make sure that the doctors who have in the health ecosystem are the best possible doctors. So I would start with that. That's number one. Number two, you know, in part, the reason I accept a talk like this, the reason I actually engage in these kind of conversations, because I think we are all better off if we all understand the fullness of the picture. Because you as a medical student, you as a doctor, are going to have the opportunity to be part of the conversation that generates health. And if you understand what generates health, you can actually help shift those who are in a position to make change happen in the right direction. So my answer, so my very specific answer to medical students is make sure you're an excellent doctor, but also understand what generates health so you can be part of a conversation that shifts our health achievement in the right direction. From Esther Thatcher, thoughts on how we think about epistemology. How do we communicate about what we know about health, and how does it move us forward around mis and disinformation? Yeah, I think it's a super interesting question, actually. So thank you for the question. I actually think, I must admit, where my mind went to as I read this is I probably should actually add a point in this presentation as I evolve it over time, about how we know what we know as one of the things that the moment should push us to rethink. Because I do think that the moment should also push us to say, what is knowledge? Where do we get it from? Why do we think we know the things we know? And I think that actually bears conversation. You know, in medicine, and let's say the science of population health or of biomedicine, you know, we have long had shibboleths that are narrow and not helpful. For example, we have had shibboleths like the randomized control trial is the only way to determine causality, or even worse, randomized control trial gives us certainty about causality. I mean, this is wrong. It's simply wrong. There are many, causality is a very complex set of questions, and randomized control trial are just as frequently wrong as they are right. So I think us asking why is it that we think we know what we know should be an important part of the conversation going forward. Thank you. From Kurt Stengi. Hi, Kurt. Good to see you or read you. Can you talk about scale in overcoming the communication and trustworthiness problems? How to work both on personal level and the systemic level together? Yeah, it's also super interesting, actually, how to talk about scale. You know, in the middle of COVID and when vaccines became available, I would get all these questions from the media at all times, which were like, you know, how do we get people to trust us? And my general answer was, you know, I think it's too late. Like it's you know, the old adage where if I have to say to you, trust me, you know, you've lost me. It's sort of a, if I have to be explicit, say trust me, well, you probably shouldn't trust me. You know, I think we need to build trust slowly. And how do we do that? I think we do that by being fulsome and honest and open in our conversation and communication, by having conversations like this. I am grateful to you for inviting me with and to offer some of these provocations and challenges. Now, maybe you'll never invite me again, which I would understand, but hopefully, you know, the provocation was taken in the spirit it was intended, which is just to push us to think collectively. And I am sure there are many people in the audience who will have better ideas than any of the ideas I've presented here. But I think the point is to push us to think collectively so that we can actually earn trust, both interpersonally and collectively.
Thank you. I think I will just have a final question for, I know, you know, you're leading the new School of Public Health at WashU. My question is, what can we expect from the WashU School of Public Health over the next decade? I know it's not a 1-minute question, but, or what excites you the most?
Well, you know, settle in. You know, I'll speak candidly. You know, I had led a school of public health for about a decade in Boston. I enjoyed it, and I think we did some really good things together, the community there. And I chose to come to WashU for two reasons. Number one is it was an opportunity to think about what does it mean to build an institution from the ground up, School of Public Health, which is an unusual opportunity in a lifetime, and I wanted to experience that. But number two was I was particularly intrigued, and I alluded to this earlier, to build a School of Public Health really in the middle of the country, really in a red state. And because I had grown suspicious of the narrowness of my own bias, had been in Boston for 10 years, New York for 10 years, you know, very East Coast centric. Now, of course, I agreed to take this on in March of 2024. I started here in January 2025, and then the whole world changed in January 2025. So you can all imagine, perhaps, the complexities that has occasioned. You know, I was determined to push us to start a School of Public Health with a generous understanding of our limits in public health, and that we need to be open-minded about the challenges facing the health of populations and about how we contribute to those challenges, about some of the things that I've just put in front of us right now. And wow, since January 20th, it's been an intense lens on these exact issues. So if that was my intention, it has sharpened it and elevated it. So what I'm really trying to do, separate and apart from the important but perhaps quotidian structures that we need to build to allow investigators to thrive and flourish and students to get an excellent education, is to create an environment of openness to ideas and an environment of openness to partnerships that are untraditional to what we do. You know, I have established for the school 4 new directions, which I think are out in the field. One of them is thinking differently. The other one is embracing new methods, things like AI. The other one is doing work that has applicability in context. This is the point I was making earlier about having real impact. And the other one is engaging in partnerships with less traditional partners. You know, we in health, you know, because health is such a big industry, we're sort of used to just talking to ourselves, but there's a whole other industry out there of people who actually do this work, who care about this work in the private sector, who are important. And now all of a sudden we're seeing that these people are all over the new administration. And we, I think, are well served by embracing these other perspectives and these partnerships.
Thank you so much. This brings us to the end of the public session. For those of you who are going to be the meet and greet, please stay online. I thank you again, Dr. Galea, for your presentation, and for all the attendees we have today. I hope you all enjoyed it and enjoy the rest of the day. Thank you.